É desse jeito, é desse jeito. Só leva chifre quem não faz amor direito. É desse jeito, é desse jeito. Só leva chifre quem não faz amor direito. Só leva chifre quem não faz amor direito.
In this video on Kala-Azar or Leishmaniasis, which is another vector-borne disease, we are going to talk about Kala-Azar epidemiology, the epidemiological determinants. Then we shall see about the clinical features of the disease, how to diagnose or investigations of choice under the National Vector-Borne Disease Control Program. Please remember that Kala-Azar is again one topic that you need to refer to the vector-borne disease video, as well as you should be referring to the entomology about the sandfly also. So epidemiological features, clinical features, diagnostic modalities, and last is we are going to talk about the treatment for Kala-Azar and prevention and control of Kala-Azar along with monitoring evaluation indicators. So let us start with the first topic, that is epidemiological basis or epidemiological determinants of Kala-Azar or Leishmaniasis. Leishmaniasis is a protozoal disease from genus Leishmania. If you talk about the status of Leishmania in India, please understand or recall that it is Leishmaniasis, Kala-Azar or visceral Leishmaniasis is endemic in the Bihar belt. So what is there in the Bihar belt? Same answers. We have talked about it in previous videos about lymphatic filariasis, about in Japanese encephalitis and malaria, that the Bihar belt consists of Bihar, Uttar Pradesh, West Bengal, and Jharkhand. So these are your defined areas for more cases of Kala-Azar. Next is, if you are going to talk about the agent factors, Kala-Azar is caused by various features of various types of Kala-Azar is there, that is visceral Leishmaniasis, cutaneous Leishmaniasis, mucocutaneous Leishmaniasis, and post Kala-Azar dermal Leishmaniasis, PKDL, post Kala-Azar dermal Leishmaniasis. MCQs on each of them. The visceral Leishmaniasis is caused by Leishmania donovani. The cutaneous Leishmaniasis is caused by Leishmania tropica. Mucocutaneous is caused by Leishmaniasis brasiliensis, and PKDL it happens maybe after some time post Kala-Azar dermal Leishmaniasis. It is an immune response, and predominantly you have these three basic types of agent factors and the types of disease. Coming forward, the Leishmania parasite or the protozoa, it's an intracellular parasite which lives in the macrophages and divides within the macrophages. It divides within the macrophages. So in vertebrates, and in non-vertebrates, that is the insects, vertebrates, that is the insects. In vertebrates, it is in an amastigote form, whereas in the non-vertebrates, it is in the promastigote form. The amastigote form of the Leishmania within the cell is what we call as Leishmanian body. or the Donovan body, and the promastigote forms, these are usually flagellar. So everything will come into place once we discuss about the investigation of choice. So these are your types of pathological features about leishmaniasis. If you talk about the reservoir, that could be an MCQ reservoir. Please remember that for Kala Azar, Indian type of Kala Azar, man is the only reservoir. Man is the only reservoir for Kala Azar, Indian type. Whereas for other types of Kala Azar, other types of leishmaniasis, we may also have an animal reservoir. But the MCQ could be that the Indian type of Kala Azar, man is the only reservoir. Next, if we are going to talk about the host factors, in the host factors, let us first talk about the age. Please remember, all ages may be affected. However, there is a question that the peak age is from 6 years to 9-year-old children. Why? Because they are mostly playing, and they are the children who are exploring things, and the sandfly, which is the vector for this disease, lives in cool, damp places, in creeks, in holes. So these children have higher chance. It somehow peaks during this time. If you talk about the gender, the males are twice more likely than the females. If you talk about the gender, if you talk about the other host factors, that is the low socioeconomic status, low literacy level, are propitiating factors. Malnutrition is a very important risk factor for having Kala Azar. So Kala Azar actually affects, that's a saying, that Kala Azar affects the poorest of the poor. So the more poor people are, there is a higher chance of developing Kala Azar. Next is, if we talk about the environmental factors, the season has a typical characteristic feature. This could be your MCQ. The seasons which are there, the epidemic seasons that we have seen is November or March, April. These are the epidemic seasons. However, it has been observed that they are more, generally speaking, the Kala Azar is seen to be more during and after rains. So there is a difference of fact and information over here. It is generally seen during and after rains. However, if it occurs during November or March, April, we have seen that the previous epidemics were during this time. So off season, or maybe in November or in March, April, if the Kala Azar, many cases are coming, there is a chance that the outbreak potential is there. So this season is for outbreak potential. However, this is generally seen that most of the cases will occur during this time. Next is, what are the vector for this? The vector is a sandfly. What is the vector? Phlebotomous. So phlebotomous is of 3 types. Like, many phlebotomi are there, but Phlebotomous argentipes, Phlebotomous papatasi, and Phlebotomous sargenti. So argentipes is for Kala Azar predominantly, that is the visceral leishmaniasis. Papatasi and sargenti, these are for cutaneous leishmaniasis predominantly. A few salient features of sandfly we will discuss over here, but please, I'd like to remind you again that in case you have not seen the video on entomological parameters or entomology under environment, please see the sandfly section over there. But a few points over sandfly, I would like to talk that sandfly, you know that it loves to live in cool, damp places. It is a nocturnal insect. And that is the reason it usually bites 6 to 9-year-old children. The predominant biting time is nocturnal time, and it is highly anthrophily. It shows anthrophily. Anthrophily means it has a high chance, like it loves the human blood, right? That is what is anthrophily. So these features of sandfly will make it more vectorogenic for rural areas or poor living conditions. Next, if we'll talk about is mechanism of transmission. If you talk about the mechanism of transmission, it can be by three types. The three broad types is, first is of course common sense answer, that is a bite of a sandfly. So direct inoculation of the protozoa into the blood, that is direct inoculation by the sandfly bite. Second mechanism is by contact, not by contact by touch to touch, it is by crushing of the insect during feed. And third is not very common, it's a rare, that is through blood products or blood transfusion. So that is through blood transfusion. So remember that the bite of sandfly, of course, that is the most common route of transmission. Crushing is not very common, and blood is rare. Next, if we talk about the incubation period, the incubation period for Kala-Azar, it's like too elongated. The incubation period roughly ranges from 10 days to 2 years. Average we take normally 1 to 4 months. Average we take is 1 month to 4 months. This is easy for me to remember. I don't get confused in this, that there is an external incubation period also. What is an external incubation period? Within the sandfly. So the incubation period in the sandfly is ranging from 1 to 4 weeks. So that makes my life easy, that I don't have to remember a lot. External incubation period 1 to 4 weeks, and internal or the normal incubation period is 1 to 4 months. Next is about the types of Kala-Azar or types of Leishmaniasis. Leishmaniasis, the clinical type. Leishmaniasis, the clinical type. The clinical type, as we had already discussed, it could be visceral Leishmaniasis or cutaneous Leishmaniasis, mucocutaneous Leishmaniasis, or post-Kala-Azar dermal Leishmaniasis. So the visceral Leishmaniasis or Kala-Azar presents with a classical triad of fever plus hepatosplenomegaly. It could be hepatomegaly or splenomegaly or hepatosplenomegaly plus weight loss. So that's a classical triad of this, plus there is anemia also as an add-on feature. So fever, hepatosplenomegaly, hepatomegaly or splenomegaly or both, hepatosplenomegaly plus weight loss, that's a classical triad for Kala-Azar. If you talk about cutaneous Leishmaniasis, in cutaneous Leishmaniasis there is predominantly skin ulcers, ulceration of the skin. Now this skin ulcers is in exposed parts, and these are painful skin ulcers. So this patient is inevitably going to come to a dermatologist or a physician for the treatment. The mucocutaneous Leishmaniasis, that is a disfiguring disease where there is destruction, there is rapid destruction of the mucus area, of nose, of mouth or pharynx. So it's a very disfiguring type of disease where you have this rapid destruction. The post-Kala-Azar dermal Leishmaniasis, it consists of multiple small nodular infiltrations on the skin, and these nodules are filled of the protozoa. So these are multiple nodular infiltrations on skin which are filled with the microorganism. So coming now to some of the case definitions within the Kala-Azar program. Next is we are going to talk about the case definitions. Like when would you say a case of Kala-Azar? When will you say a treated case? When will you say a confirmed case? When will you say a probable case? See, case definitions of Kala-Azar is based on what is a case. First MCQ, what is a case of Kala-Azar? Case of Kala-Azar is any fever for more than MCQ 2 weeks. It should be fever for more than 2 weeks, plus there should be splenomegaly with a rapid diagnostic test positive. With a rapid diagnostic test positive or a biopsy positive, right? So please remember that is known as a case. Who is known as a case? It has to be fever with splenomegaly, with rapid diagnostic test positive or a biopsy positive. So this has to be there. It has to be some diagnostic modality, either rapid diagnostic test. We are going to discuss about all these things. What is RDT? What is RDT? Rapid diagnostic test. And BX is the biopsy. BX is the biopsy. Now the case can further be of, like, it comprises, case is an improper definition. There are actually two types of cases. One is known as a probable case, or it could be a confirmed case. So this is what is expected in the exam. Nobody is going to ask you case. Everybody knows it has to be some laboratory confirmation, right? If you talk about the case, it could be probable case or it could be a confirmed case. What is a probable case? I think most of you understand it now. It is features of Kala-Azar, that is fever with hepatomegaly or splenomegaly. So features of Kala-Azar plus a rapid diagnostic test positive. Rapid diagnostic test positive. But what is, when will you call a confirmed case? When will you call a confirmed case? This is important for you to remember, that it is nothing but Kala-Azar plus there has to be a parasitological confirmation. This parasitological confirmation is not by rapid diagnostic test. It should be either by microscopy or the other methods. We need to have parasitological confirmation. So that is the gold standard to see a Leishmanian Donovan body inside the sample. So that is what is a confirmed case. So what is a confirmed case? Confirmed case is a parasitological confirmation, whereas if you have only rapid diagnostic test, that is known as a probable case. However, both are known as case. What is a cure and what is a final cure? Now again you will say that, sir, how is it possible? That's how the PSM case definition works. Cure. If you see cure, what is a cure? Cure is a person who has taken complete treatment for Kala-Azar, maybe for 28 days or for single injection amphotericin B or something, who has taken complete treatment without any default and no signs and symptoms of disease. There are no signs and symptoms of disease. The point to be noted is complete treatment, either single injection or 28-day tablets, or will do treatments. So that is known as a cure. But what is a final cure? Final cure is a person who is no sign and symptoms. Who is a cure, that is no signs and symptoms of disease, even after 6 months of last or the previous treatment. So post-treatment, if there are no signs and symptoms for 6 months, that is known as final cure. What is a final cure? No signs symptoms even after 6th month. That means for 6 months you had no signs and symptoms after your treatment was over. Next is, I think, easy ones. What is a what is a no response? What is a no response? And what is a relapse? No response means that the patient does not respond. So MCQ, there is persistence of sign and symptom. There is persistence of sign and symptoms even after 2 weeks of treatment. So that means if the signs still persist even after 2 weeks of treatment completion, either miltefosine or the single dose, that is known as non-responder or no response. What is caused as what is called as relapse? If there is resurgence of the presence of the sign symptoms within how much time? Within 6 months, because after 6 months that will be known as final cure. Done. So relapse is what? Relapse is presence of sign and symptoms within. So that is a resurgence of sign and symptoms, a resurgence of sign and symptoms within 6 months of treatment. That is known as relapse. So you have these 4 definitions: what is a cure, what is a final cure, what is no response, and what is relapse, and you also did what is a case. So these are your case definitions for Kala-Azar. Next, let us come to the diagnosis of Kala-Azar or Leishmaniasis. The first is something known as a rapid diagnostic test. What are the diagnostic modalities available under the National Vector-Borne Disease Control Program? These are the approved tests. So RDT is an approved test by the Government of India. RDT is a rapid diagnostic test. Rapid diagnostic test. This RDT, the name of the rapid diagnostic test is RK39. R stands for recombinant K39 antigen. So that's the name of the kit. So what is the use of RK39? It tells you the qualitative assessment of antibody for Kala-Azar or visceral leishmaniasis or Leishmania donovani in the serum. So this is what it tells you, the qualitative assessment. It does not tell you the how much antibody is there. It tells you how much is the antibody there or not there. The second test is we can use parasitological investigations. So the parasitological investigations, these are the gold standard. If they are positive, that is known as a confirmed case of Kala-Azar. What is parasitological? It is demonstration of LD bodies, Leishmania donovan bodies intracellularly. So it is done on the biopsy sample of bone marrow, liver, from the skin nodules or the lymph nodes. So these are the areas from which the parasitological sample can be taken. Third test that we can have is the aldehyde test. Aldehyde test, it was approved before. Nowadays we do not use it. It is only used for some surveillance procedure from surveillance point of view. So it is known as aldehyde test of Napier. This is a good, very easy to perform. You take 1 to 2 ml of serum. So to 1 to 2 ml of serum, we will add 40% of formalin. We add 40% of formalin and this will give us a milky white opacity. Now, if this opacity is within 30 minutes, within 2 minutes to 30 minutes, it is known as a positive test. If it is after 30 minutes, it is known as a not valid or a negative test. Not valid or a negative test, right? So this aldehyde test of Napier is pretty easy to perform, but the point is that 30 minutes wasting, and it's not usually done at field level because of logistic problems, and it is good for surveillance of Kala-Azar. Any surveillance of Leishmaniasis, we will do aldehyde test of Napier. The fourth investigation that you can study is serological test. Serological test is of many types. You have already done. We have this IFAT method. IFAT method, that is indirect fluorescent antibody test. Indirect fluorescent antibody test. We have studied about RK39. These are all the approved methods. Then we have ELISA method. Next is there is also something known as DAT, that is rapid direct agglutination test. So this is like various serological methods are available, out of which the RK39 is currently used as the field test, or we can also use the aldehyde test, but it is only used for surveillance method. Just a brief point about RK39. What is RK39? You have read it is a recombinant kit 39. So just have a look at the screen, that if you see this, this is a snapshot from the RK39 kit. Now the point I want to discuss is that if this is the dipstick, on this if you put the sample of the patient, the blood, the sample will be put here. Now there are two lines which will be formed. One is a test line, one is a control line, as you can see here. If the test line is there, of course, if the test line is there, that is known as a positive result. But if the control line is also there, this actually, the sample you put here, this will travel to the control line. If in case it does not travel to the control line, that is known as invalid test. This is a not valid test. Are you getting it? This is a not valid because there is no control line. Similarly, in this, even if you get the first line as positive, that means this first line is positive and the second line was absent, control line was absent, this is also invalid test. This is also invalid test. So for test to be valid, you should have a control line. Then you see whether the test was positive or not positive. So that was regarding a brief about the RK39. The last test that I think everybody of you must be waiting for it. This is one of the tests which is done by usually in the dermat clinics. So that is known as Leishman test. Leishman test. It is also known as Leishman test or Montenegro test. Montenegro test. So in this, nothing very big, it's no rocket science. So what is a Leishman test? You will inject, it's a skin reaction test. First MCQ. Second, how much of what you will inject? We will inject 0.1 ml intradermal injection of the antigen. What antigen we are using? We are using the pro-mastigot form of Leishmania donovani. Leishmania donovani. You remember pro-mastigot was found in which organism? It was found in the insects or the non-vertebrates. So that is what we are going to do. We are going to inject this. Now after this, if you have more than 5 mm of induration, we usually say it's a positive test. Next we come to is what are the monitoring and evaluation indicators in Kala-Azar. So if you just look at the monitoring and evaluation indicators, first is the detection rate. What is the detection rate? It is number of new cases of Kala-Azar divided by the population under survey multiplied by 100. That is the detection rate. What do you mean by the treatment completion rate or the completion rate? It is number of population with treatment completed. What do you mean by treatment completed? Patient had taken full 28 days of cycle of miltefosine. So number of population with treatment completed divided by the number of population who started treatment on treatment started multiplied by 100. So number of people who start, out of them how many you complete. So normally we say completion rate should be more than 90%. Coverage rate of the vector control, it is number of houses protected. Number of houses protected, that is by use of sprays. Just now we are going to do about the sprays in sandfly or Kala-Azar, divided by the number of houses or households at risk multiplied by 100. What is a final cure rate? You remember what was a cure rate and what was a final cure rate? It is number of people who have no signs and symptoms after 6 months or till 6 months. Final cure rate is number of people with final cure divided by number of population on treatment started or number of cases. So the treatment failure rate could be important. That means it takes into account no response, number of no response patients. Plus it also takes into account number of relapse cases. Plus it also takes into account number of people who have died due to or pertaining to Kala-Azar. It is not that the patient had Kala-Azar, he met with an accident, that comes under treatment failure. Treatment failure is no response or relapse or death. Divided by number of treatment started cases. Number of treatment started cases. All are multiplied, all are to be, please remember, multiplied with 100, multiplied with 100, multiplied with 100. All are expressed in percentages. Last, what is a loss to follow-up rate? Loss to follow-up, that means the patient started treatment and did not come back. So that is given by the number of defaulters plus number of loss to follow-up. Number of loss to follow-up divided by total number of treatment started people. Multiplicative factor is again 100. So remember, these are your 6 indicators which are used in Kala-Azar: detection rate, completion rate, coverage rate, final cure rate, treatment failure rate, and loss to follow-up rate. Last topic to discuss is about prevention and control of Kala-Azar. Prevention and control of visceral leishmaniasis or Kala-Azar. The prevention and control, what is the drug of choice? See, in the exam, they may ask you, they may not ask you, they may tell you, they may not tell you under the program or question from pharmacology point of view. Drug of choice will usually be a pharma question, right? So the best drug of choice that we have today is a liposomal. It's a liposomal amphotericin B. Amphotericin B. So it's in fact a liposomal amphotericin B, we call it as LAM, which is the drug of choice. It is highly effective. It is given at the rate of 10 milligram per kg body weight. So that is what is the use of liposomal amphotericin B, that even in single dose it may treat Kala-Azar. The second drug that we can use is please remember that is the order, so follow this order only. The second drug that we can use under the program is miltefosine. Miltefosine. So miltefosine can be given, it is usually given to age more than 12 years. Okay, so age more than 12 years, the dose is age more than 12 years and weight more than 25 kgs. The dose is given at the rate of 50 milligram BD dose. It is given at the rate of 50 milligram BD dose. If the age is more than 12 and weight is somehow less than 25 kilograms, now we will give them 50 milligram OD dose. 50 milligram OD dose. If the weight is less than 25 and the child is also less than 12 years, if the child is less than 12 years, whatever the weight is, less than 25, of course it has to be less than 25. In those cases, we will give at the rate of 2.5 milligram per kg body weight. All these are given till 28 days, and liver follow-up and renal follow-up is done every month after this. So miltefosine, age more than 12 kg, age more than 12 years, weight more than 25 or weight less than 25, and if age is less than 12 years, in those cases given at the per kg body weight 2.5 milligram, given for 28 days. It is available as miltefosine oral capsules. The other drugs which may be used as, we can use amphotericin B, we can use paramomycin. So the other drugs which may be used are simple amphotericin B, not the liposomal component, or we can have paramomycin. So just to finish off, a lot of controversies there among the students. Sir, what to mark, what not to mark. So what happens is that in case you get a question on this, under the National Vector-Borne Disease Control Program, the guidelines are that what is the first line of treatment. The first line of treatment is liposomal amphotericin B, given at the dose of 10 milligram per kg body weight, right? In case LAMP is not available, the second line of drug that is there is miltefosine with paramomycin. Miltefosine is, we already taught, it is given at the rate of 50 milligram BD dose for normal adult people, and less than that it is 50 alternate or OD dose or 2.5 milligram. So miltefosine plus paramomycin. Paramomycin is given at the dose of 11 to 12 milligram per kg body weight. This is to be given for 10 days. So if you get this in the option, paramomycin for 10 days plus miltefosine for 28 days, this is the second line of drug. The third line of drug is plain injection amphotericin B. Fourth line would be plain miltefosine. So depend on what is the funding by the state, or depending on how much the Kala Azar is endemic in that area. Bihar is using liposomal amphotericin B, most of the districts. And in some districts, we are giving miltefosine plus paramomycin. In some districts, it's only miltefosine, depends on the endemicity. Next is about the control, that is of the control of the vector, that is the sandfly control. Lot of questions have come and lot of questions have been asked on this, that how do you control a sandfly? Try understanding that sandfly till date is sensitive to DDT. The first line of insecticide that is used in major parts, Bihar is a pretty big state, Uttar Pradesh is a big state, West Bengal is a big state. You cannot afford to have all the newer insecticide just for Kala Azar control. And secondly, you also know that sandfly does not fly. So if sandfly is not flying, that sandfly has a limited area to be done. So the drug of choice, the insecticide of choice over here is DDT. If in case DDT is not there, the second line that we have is BHC. In case in some areas, WHO has definitely said that use of pyrethrins may be done for sandfly, but this is like questionable because it is just a may be done. In India, DDT is still being used. Second line we use is BHC. DDT is sprayed at the rate of 1 to 2 gram per meter square area, and it is effective for sandfly control, right? So no confusions on this. Pyrethrins may be used if WHO has actually recommended for use of pyrethrin, but under National Vector-Borne Disease Control Program, we are still with DDT and BHC. So with that, we'd like to close this topic. We have covered Kala Azar. We talked about the epidemiological things. We talked about the clinical features. We talked about the diagnosis, and we also talked about the prevention and control, along with monitoring and evaluation indicators of Kala Azar. Thank you so much.